The following episode is brought to you by the American Urological Association. This episode features content from the AUA2025 meeting in Las Vegas. For more information on how to claim CME credit for your participation or to view faculty disclosures, please visit the AUA University. This educational activity is supported by an independent educational grant from Janssen Biotech Inc., administered by Janssen Scientific Affairs, LLC.
Okay, great. We'll get started. So good morning. Appreciate you attending the course this morning. We'd like to make it very interactive, the course. If you have a question, again, I'm going to try to engage everyone. Please don't be shy to ask a question, make a comment about a case. You know, if you have a different approach, something you would like to kind of have interaction about, but please use the microphone. There's two in the room. They're in the center aisle. So if you could please go to the microphone, it would kind of help than my having to reiterate the question. So please don't be shy to use the microphone. We also have a live interactive audience online. And so we'll be monitoring the chat function, and some questions might come in online. I have a few housekeeping details I have to read for the first few moments before we get into the course. I'm Kamal Pohar. I'm from Ohio State University. I'm the course director. Dr. Fred Witch is my colleague from the Netherlands. And Dr. Ashish Kamat will join us here shortly from MD Anderson. He's just finishing up a talk at another course. He's on his way in the next 5 minutes or so. He's finishing up, giving a talk at another session here. So he'll be here shortly. A few housekeeping details. As part of the disclosure policy for the AUA, relationships with ACCME defined ineligible companies are relevant to the educational content of this CME session to mitigate any conflicts of interest. The full disclosure policy and the disclosures of the faculty are all listed online. And we're going to move into the first kind of short mini didactic session. So we're having a number of folks continue to join us, which is terrific. I'm just going to reiterate one comment. We'd like this to be a very interactive session, so please don't be shy. Engage us as we go through the cases. There's microphones in the center aisle. Please use the microphone if you have a question, you have a comment, you have an alternative view of management. Please use the microphones. Okay. I am trying to advance this slide. Okay, the course learning objectives, they're all in the course materials that we provided. They're online, so I'm not going to go over the course objectives, but certainly please review them in your packages. So we're going to go through a short, we have three relatively short kind of didactics that each of us are going to present to set the stage of topics that we want to highlight that I think are kind of state-of-the-art, very practical things that all of us deal with on a daily basis. And the focus of my talk is TURBT. There are my disclosures. Okay. Guidelines are really important. You know, we hear that a lot in our meeting, you know, AUA guidelines. I think they're very important to set the stage and allow us, you know, to really be in compliance with the best knowledge that we have today. So I'm going to have a few guideline statements as part of my introduction. So the first one, at the time of resection of suspected bladder cancer, a clinician should perform a thorough cystoscopic examination of a patient's urethra and bladder that evaluates and documents tumor size, location, configuration, number, and mucosal abnormalities. It's a clinical principle. I don't think we can overlook the fact documentation, clarity of evaluation of the endoscopic findings and documenting that in your note so you can reference it later is very important. Number two, at initial diagnosis of a patient with bladder cancer, a clinician should perform a complete visual resection of the bladder tumors when technically feasible. So really working on strategies to really eradicate and define all signs of visible disease within a window of safety is critically important. Why does quality of TURBT matter? Well, it matters because we have evidence that completeness of a resection can improve outcomes after intravesical therapy for non-muscle invasive bladder cancer patients, so subsequent chemotherapeutic agents, subsequent BCG, better outcomes after radiation therapy. We talk a lot about the paradigm of TMT, or trimodal therapy, as a bladder-sparing treatment for muscle-invasive bladder cancer, and improving radiation outcome by completeness of resection is important. Possibly higher PT0 rates after neoadjuvant chemotherapy for muscle-invasive bladder cancer. So a lot of impact at really working towards skills and strategies of all of us improving our ability to eradicate all signs of visible disease. I'm going to present a series of papers briefly at different levels to demonstrate how quality of TURBT really impacts outcomes that are important to patients and meaning important to us. So Scotland is not a very large country. So this is a very nice governmental effort in a public-based health system of a study of advising all practicing urologists about key parameters that we all want to achieve after TURBT, and they're listed here, using a bladder diagram, giving a single dose of perioperative chemotherapy following a TURBT in the appropriate patient, having muscle present in the specimen, and knowing when to recognize a repeat TURBT or a completion TURBT in a high-risk patient is important. So parameters, I think we all recognize that are important to care. So they looked at quality over the entire country over a series of a couple of efforts, looked at the data and realized quality parameters were not overly high in every one of these categories. So they implemented a compliance program through all of Scotland, trying to focus on educating urologists about the importance of these variables and measuring their ability to do audit and feedback over a period of 3 years. Could you start to improve quality of TURBT, practice patterns over a period of time at a very global level? And what they found was that in the very top box, that's looking at the country at large. And 1, 2, 3, those are the 3 years of their quality improvement program for 3 consecutive years, looking at all urologists and about 1,800 patients, first-time diagnosis of suspected non-muscle invasive bladder cancer at the time of TURBT. The top box is looking at the entire country. The middle box is looking at a study cohort. They selected a sample of specific hospitals and regions and measured over that 3-year period of time. And the bottom box is based on hospital group, and that's based on volume, where A are hospitals that did less than 60 TURBTs in a year, B was 60 to 90, and C was greater than 90. And you can see over that period of time, there's no control group. This is an observational cohort, audit and feedback, providing data every year to different categories of how are we doing. And you can see there the parameters they achieved, pretty good. 67% of patients received perioperative chemotherapy. There was a 13% recurrence rate at the first follow-up cystoscopy. Residual cancer was 33% in patients that underwent a repeat TURBT for appropriate indications, and understaging was about 3%. So I think overall pretty acceptable. Clearly we want to keep improving on these results, but based on that, looks pretty acceptable. This is just another figure taken from their paper. It's looking at volume of TURBT again by hospital group ABC, but it's also looking at the trainee and a consultant. So a qualified urologist in red versus a trainee in the black diamonds. And you see there that I highlight that in the hospital with high volumes where the trainees were doing a number of the TURBTs, the results were not that discrepant. The trainees actually did better. And it just goes to show you focus of TURBT quality. Doesn't matter how experienced the individual is, inexperienced the individual, focusing on quality is important for everybody. And focus is probably the important message here, that regardless of your level of training, volume of your volume of TURBT procedures, there's the results can certainly be balanced as you focus on quality. Okay, checklists. This is something I still utilize in my practice so many years later after, thousands of TURBTs. This is a publication of, can you do something pretty simple in your practice and implement a checklist? And so this is a publication that just looks at clinical factors, operating room factors, that if you just have a checklist and you describe very clearly in your operative note the number of tumors, size of the largest tumor, characteristics, did you think there was carcinoma in situ? Did you get muscle in the specimen? Did you remember to do an exam under anesthesia? So a very simple checklist of 10 factors. If you just document all of this in your note, and I'm going to show you the next slide. This is from academic institutions with very high volume bladder cancer care. So this is in the hands of individuals that almost exclusively focus on bladder cancer care. And you can see before the checklist was implemented and after the checklist, even in the hands of experienced individuals, visual complete resection documentation to remember 2 weeks, 3 weeks later when you see the patient. How are you going to remember? Did you remove all the tumor, yes or no? I mean, you need to know that. So you see how the documentation got better. People can remember. And muscle in the specimen, do I believe I removed, this isn't pathologic data, this is in the operating room. Did you document with your eyes, do you feel like confident you got muscle? Because if you feel like you did and the pathologist reports you didn't, that's probably a good time to engage your pathologist. I think I got muscle. Could you please look at it again? Because I'm pretty sure I did. I visualized it in the operating room. Okay. One last thing I want to put up about continuing to emphasize ways to keep improving quality of TURBT. This is a study from Northwestern University, and they looked at a number of urologists in their group, 11 different urologists, performing TURBT. And they looked at the data over a period of a few years about one parameter. They were really looking at, did you get muscle in the specimen? So they picked one hard endpoint, a quality parameter that we all espouse to. And they looked at the rates and they said, well, the rates are pretty discrepant amongst our group. Some are disappointing, some are better, but certainly we can all get better. So they implemented a scorecard where in a blinded manner, they would share data of the entire group and then personally share your data with you to show over the next few years, what was your ability to acquire muscle in the specimen. And so what all of these pictorials, and they're all in your course handouts, demonstrate is I selected one surgeon in particular, Surgeon 7, and what they demonstrated here is with that one surgeon, as you continue to provide feedback, that one surgeon went from having rates of between 40 to 50% muscle in the specimen. After scorecards were implemented, the final column in the table, you can see 100%, 100%, 67, 91, 100. The surgeon continued to get better, and you see the volume was consistent, around 30 to 35 procedures that required a TURBT for T1 bladder cancer every year. And no doubt they demonstrated there was a very favorable impact that after their quality improvement program, their sharing scorecards, recurrence-free survival was better. So it impacted a hard clinical endpoint that was important to patients. For their entire group of urologists doing TURBTs, you can see it has a very important outcome for patients. When should you do a repeat TURBT? Well, I'm going to start AUA guidelines, again, very important. Let's start with the category strength of recommendation of a B. So clearly, if you've left tumor behind, you've documented that, you know the importance of going back. There are reasons why you can't remove all of the tumor at the first TURBT sometimes, and it's better to be in that scenario than potentially cause harm and come back and repeat the TURBT within an appropriate period of time. So that's a high-level recommendation. When it's technically feasible, go back and repeat the procedure and eradicate all signs of disease. The other one we're very well versed on is in the setting of T1 bladder cancer. Many guidelines around the world recommend performing a repeat TURBT of the primary tumor site and include muscularis propria. Now, a grade C recommendation is in high-risk, high-grade TA bladder tumors. Consider a repeat TURBT. It was part of one of the pretest questions. You know, should you do a repeat TURBT in high-grade TA bladder cancer? It's a grade C recommendation. Okay, and you see up there expert opinion. If you're considering bladder preservation in an individual with variant histology with high-risk non-muscle invasive bladder cancer, you want to consider a repeat TURBT. Okay, I'm going to pass this slide for the sake of time, and I'm just going to put together my final slide before I turn it over to the first case today. This is just a series of patients with T1 bladder cancer, a large amalgamated series of patients put together retrospectively. The orange and the blue up there, the orange are patients that had a repeat resection in appropriate cases versus those who did not. And you can see the difference it made in progression-free survival, disease-specific survival, those that had a repeat TURBT, and this is essentially mostly T1 bladder cancer patients. And so I emphasize again, at kind of a population-based level, despite the fact this is retrospective and so forth, with some of the limitations, you know, that TURBT can really impact quality of care of patients. Okay, let's move on to our first case. So I'm going to present a case. We're going to engage Dr. Witches, Dr. Kamat. I want to engage you as well, please, so please use your microphones. Okay, case one. 67-year-old active male with a history of hypertension, hyperlipidemia, prior cigarette use for many years. He was evaluated for gross hematuria. He has stable LUTs, lower urinary tract symptoms, characterized by mostly storage symptoms. He was started on tamsulosin almost 3 years ago. He had a CT urogram for gross hematuria that was unremarkable other than small filling defects in the bladder suggestive of clot. A urine cytology was collected. It was suspicious for high-grade urothelial cancer. I'm not sure if everybody in the audience would do an office cystoscopy here in the setting of hematuria. You see some filling defects. You have a cytology. Would you do an office cystoscopy or not? That's something I'll ask the panel here in a moment. But multiple papillary tumors were identified. Dr. Witches, Dr. Kamat, what do you think? Would you do a cysto in that scenario? Do you need one?
I think I would do a cysto just to make sure that it's not a clot, but it's something different. And, you know, if you see one small tumor, or in this case, more tumors, that makes some impact for the planning of the TOR.
What do you think?
Yeah, no, I would do office cystoscopies, and over the years I've been doing office cystoscopies like this to show the patient actually on the screen where their index tumor was. The reason for that is now I have some patients who are 15, 20 years out, right? And I tell the patients, hey, this is where your index tumor is. When they come back after many years, sometimes on annual surveillance, they'll remind me, doctor, it was in that corner. Look there carefully, right? So I get the patients involved in their cystoscopy, which I think is good for shared decision-making. Patients feel involved and they can actually see their tumor.
Yeah. Anyone feel differently? I mean, the reality is probably not going to impact your next management step in care, but everyone agree with, you know, kind of engages the patient a little more, provides knowledge, builds a relationship. Okay. Okay, patient was taken to the operating room. An exam under anesthesia was done. Prostate's moderately enlarged, no palpable abnormalities. Bladder's mobile without a palpable mass. Important to always do an EUA. At the time of cystoscopy, normal urethra with lateral lobe enlargement, several bladder trabeculations and cellules. 4 papillary tumors were noted. On the posterior wall and the right lateral wall, you see the sizes there. 1 additional tumor was noted, 2 centimeters in size, in a bladder diverticulum just above the trigone on the posterior wall. A complete visual TURBT was done. 3 specimens were submitted to pathology. Dr. Kamat, papillary tumor, suspicious cytology, tumor in a diverticulum. Is there value to give perioperative chemotherapy in this patient?
So, you put a little complicated case here on purpose, I'm sure, but the data suggests that if you have a patient that you know and think you're definitely going to give adjuvant therapy to, and especially if it's immunotherapy with BCG, then there's no benefit to perioperative therapy. So in this patient with the cytology being positive, with multiple tumors, large tumors, I'm almost thinking I'm going to have to give this patient BCG. And in that case, Richard Sylvester's data suggests you actually harm patients by giving chemo. I don't think that's true. I think that's a statistical anomaly, but you don't help them, so I would not.
Dr. Richards, what do you think?
Yeah, exactly the same. And the fact that you did apparently a complete TOR and a diverticulum, might be a little bit afraid of a perforation. That, of course, is a contraindication for a single post-op installation.
Yeah, I think, one has to be a little... one unique factor of the case. Again, I think this is practical. I think this is a case we all face. I don't think this is overly unusual. Bladder diverticulum and having tumors are not that common, but, deep resection in that diverticulum, you may be a little more cautious about giving the perioperative chemotherapy drug. And we talked about the fact it's very likely this patient has high-risk non-muscle invasive bladder cancer using your best judgment of the factors we put together. So there's probably not a benefit. But I don't think there's a harm if you gave it. I don't think there's a lot of harm here, if you felt it was safe to do so. I don't think that's anything, we're doing anything that would, one would feel was maybe inappropriate, or you would think maybe I shouldn't have done that kind of thing. Okay. I was going to ask that second bullet point. Sorry, I jumped over it for a second. Enhanced cystoscopy has a lot of attention today. Any comment if you felt about enhanced cystoscopy? You would routinely use it if you had it available in this procedure?
Yes.
Yeah, I think, it's enhanced cystoscopy. It's like using a high-definition screen. Why would you not use it if you have it, right? Is it an absolute game changer? No. But if you have it, use it. It will help you detect more tumors, maybe some CIS, et cetera, et cetera. And the photo trial, and I'm sure you mentioned that because I saw the slide just pop up, has a lot of faults.
Good, because I want to come to that for a moment. Dr. Richards, you would agree with the enhanced cystoscopy?
Yeah, of course, and I think it does impact on therapy, it does improve prognosis, etc. So if you've got it, you just have to use it.
Yeah, I think the point that we want to emphasize here, it improves visualization, so number of tumors, but there's a hard clinical endpoint of early recurrence rates are impacted in a favorable way. So again, an endpoint that affects patients positively. If I could get a show of hands, who uses enhanced cystoscopy at TURBT in the room? Who has who has access to the technology? So I think each year we do the course, we get a few more hands go up now, but I still think less than half the room from what I saw that we have availability to the technology or use it. Okay, I think this is important. This is a publication you may be aware of in the New England Journal of Medicine, Evidence, and it's a publication from the UK where the endpoint was a 3-year recurrence-free survival. So all the studies, really conducted mostly prior to this randomized trial of blue light TURBT versus white light TURBT. We're looking at a much earlier endpoint, 6 to 12 months. So this is a pragmatic trial done in the UK, randomizing patients and looking at the 3-year endpoint. You see on the curves, there's no difference. And so that brings up a conversation, does enhanced cystoscopy, specifically blue light cystoscopy, really have a benefit? So Dr. Kamat, you brought up the photo trial, and this is the photo trial. So what do you think about the study design, any limitations to how to interpret this data?
Tons of limitations, and we only have 2 hours, right? But again, the PI Rakesh here is a friend of mine, and kudos to him for finishing this trial. Yeah. But the trial was designed to look at the impact of what you do today on something that happens 3 years later. Clearly, it doesn't make any sense that your resection today, in the absence of appropriate treatment, which these patients did not get, would affect something that happens 3 years later, number one. Number two, look at the curves. There's a separation initially in favor of blue light, which makes sense. But later on, after 24 months, they cross, and there's no difference, which again makes sense. And then the mix of patients in this trial wasn't really reflective of where we actually use blue light. It was completely a hodgepodge of patients mixed. They didn't get appropriate BCG, et cetera, et cetera. And the last thing I want to say, because people often hear New England Journal of Medicine, and they think that the editors and the reviewers are really high quality. Yes, they are. But this is New England Journal of Medicine evidence, which is open access. You can pay a charge to get your paper published.
Yeah. So the point here is the impact of the technology is really early term. later recurrence, you might suggest potentially epithelial field defect is likely the etiology or the mechanism by how the later recurrences happen. So I think certainly enhanced cystoscopy still is important to utilize. And here's the AUA statement. You can see it on the slide about the view about using blue light cystoscopy as well as NBI. So, if that potentially you have in the operating room, I don't think many do, but, if you do, certainly it's valuable to use the technology. The data is not as strong in terms of affecting recurrence-free survival, but certainly there's no doubt you can detect more tumors, papillary, as well as flat carcinoma in situ lesions with that technology as well. And so if you have it available, it's a grade C evidence strength C and a conditional recommendation by the AUA. Okay, so here's the pathology. I'll finally get to the pathology. So each of the 3 specimens, high-grade TA urothelial cancer, including the bladder diverticulum, an acquired bladder diverticulum, when no muscle is present in the diverticulum, but muscle is present in the other 2 areas, so multifocal high-grade TA. Dr. Witches, repeat TUR for this patient?
I usually wouldn't do that in the TA. If I have done the own TUR, my pathologist would confirm negative detrusor, but I'm a little bit doubting about the diverticulum. That's something, of course, you really want to inspect very well. So, I don't know, probably I would do that in this case.
You would, you said?
Yeah.
Dr. Kvat?
Mark this day. This is the first time that Dr. Witches has said he would take someone back that he did the original TURBT. Let's write this down. What happens in Vegas should not stay in Vegas for this particular thing. No, this patient, I'm a little unsure that I've resected everything for all the reasons that Fred mentioned. So in this particular patient, yes, I would want to look back and maybe not do a repeat TURBT, but look back at least.
Yeah. I wouldn't. So, if I was confident in a complete visual TURBT in this situation, muscles present at each of the sites, I wouldn't. But AUA certainly advises us, this is a grade C recommendation, that you need to be thoughtful about that. What's your level of confidence of having eradicated all of the disease? Anyone in the audience want to comment on it? This is a situation that we're all faced with, high-grade multifocal TA. Do most people do repeat TURs in this setting? I see some yeses. So a lot more yeses than no's. So a lot in the camp with Dr. Witches and Dr.
Kamal, can I just make a comment?
Sure.
Again, in expert hands, clearly, you have good resection, good judgment, but there's data that's been presented here at the AUA, which is really disheartening. Residual tumor rates were as high as 60% in patients, right? 60%. That essentially means that the urologists that were doing the resection were purposely not resecting all the tumors. I can't imagine 60% residual disease rate is something that we should tolerate as a community. So just to plead to everybody, and I'm sure everybody in this room does a good job, but 60% of the US urologists will leave disease behind at that first TURBT, and that's something that should not happen.
Dr. Witches, please.
Well, maybe, when one of the first EAU guidelines came out, there was a strong recommendation to re-TUR. And that was based on German series. And the situation in Germany is that the Niedergelassen, that's an office urologist, just takes a sort of biopsy, a small TUR, to confirm that it is a high-grade tumor, sends it to the hospitals where they do a re-TUR to confirm that it is a high-grade tumor before they do a cystectomy. And then, of course, you will have a very high risk of having residual tumor. So it depends a bit on how you look at that, but of course you have to do a good TUR.
No, these series that were presented here at the AUA were actual definitive TURs. They were not biopsies.
Mm-hmm. And I think, again, it just focuses on kind of how I opened up the course, just that focus on the quality of TURBT. It's not an easy operation. I think we could all agree. It's a challenging operation, for everyone, regardless of experience. It takes a lot of work to keep building your skills. And having a mechanism to measure your own data, your group's data, I think it's important. It's a lot of work sometimes, but I think, just keeping your own data about, are you getting muscle? Is it a complete tour? Are you using a checklist? Consider a scorecard. Okay. All right. Now, let's get on to that diverticulum. Dr. Kamat, what do you think about further management of high-grade TA within the diverticulum? I'll just give it to you that you went back and you looked again, you saw no visible tumor. And what do you think? How are you going to manage the diverticulum?
Yeah, this is where the art and judgment of us, urologists and medicine comes in, right? Because you can look at the diverticulum. Is it a true diverticulum, a false diverticulum? Is there enough backing, not enough backing? I mean, I have resected T1 tumors in a diverticulum, gotten down, and patients have done fine. Sometimes there's nothing between the tumor and the fat. It really depends upon that. So I can't say here, because I don't have cystoscopy pictures, I didn't see the CT urogram, but I don't automatically revert to a diverticulectomy.
You would go to a diverticulectomy?
No, I do not automatically go to a diverticulectomy.
I'm glad you brought that response up, because if we look at the AUA core curriculum, diverticulectomy is recommended for high-grade tumor within a diverticulum. I'm going to ask for a show of hands. Who would do a diverticulectomy in this situation? Okay, I see a couple hands go up. Who wouldn't do a diverticulectomy? Okay. Good. It's good. Anyone want to make a comment about that? Anyone want to bring up why you wouldn't do it? Dr. Witches, diverticulectomy, no diverticulectomy?
No, I wouldn't do that. But what we do at the initial TOR is small diverticulum, just coagulate the whole diverticulum, and then it might have disappeared at the next cystoscopy.
Yeah, I wouldn't. It's high-grade TA disease. It's not a high-grade T1 case. I think our decision would probably change if I presented this as high-grade T1. Yep. Would we agree with that? You referenced a couple of cases, Dr. Kamat, in your experience where you haven't done that?
Many, because a diverticulum is not a diverticulum. You can have a true diverticulum, a false diverticulum.
This one's false. It's acquired. BPH patient, trabeculation, cellules.
So this is false. So you have muscle present, right? So in this case, in a false diverticulum, by definition, you have muscle present. Yes, it might be thinner, but you can still get laminar propria resection, maybe a little bit of muscle, and treat this like a T1 high-grade patient with the caution of any T1 high-grade patient. So even in a T1 high-grade, in this case, informed decision with the patient, we'll try to save the bladder and the diverticulum.
What do you think the level of difficulty is of a diverticulectomy here? If A is very difficult, C is not difficult at all. What do you guys think about the technical challenge of a diverticulectomy just above the trigo?
Oh, I mean, again, it really depends on what it looks like, what the mouth, the size, all that stuff. I can't just give a blanket answer, but I don't think the difficulty of the diverticulectomy should influence what we do for a patient for cancer control, if that's what you are driving at.
Sure.
I mean, if I have to do a reimplant to get someone clear of disease, I will do it.
Great. Okay. So I'm going to bring Dr. Witches up. He's going to talk about intravesical therapy, current best practices, and managing complications of intravesical therapy. Then we'll go back to another case. No chance yet.
Okay, Kamal, thanks a lot. And friends, just to summarize Kamal's lecture, a TOR is a real cancer operation. Please keep that in mind, because that really is the case. Let me see how we can. There we go. So I'm going to talk about intravesical therapy according to risk groups, so let's say what the guideline says, and I'll go back, and a little bit talk about complication of intravesical therapy. So we already talked about the learning objectives, and I obviously will use the AUA guideline for this. Sometimes make a small comparison with the EAU guideline. No relevant conflicts of interest to mention. This, I guess you know. So let's say, in summarizing, low risk is a small TA, papillary tumor, and high risk is obviously high grade, T1, CIS, BCG failure as well. That's all, I think, obvious. Maybe the most interesting group is the intermediate. Your AUA says it's a low grade TA with recurrences sooner than 1 year, if it's large, if it's multifocal. And then it says high grade TA, smaller than 3 centimeters, or low grade T1. My personal remark is that I think high-grade TI I would consider high risk because it's a high-grade tumor. And my pathologist claims that T1 low-grade doesn't exist. And to be honest, I've never seen it because he never gives that as a diagnosis. Do realize if you use the risk group, and Ashish has done a very nice study, and if you would look at the EAU recommendations, you'll see that for high-grade tumors, the EAU considers, based on their risk classification, a chance of around 40% in 5 years for progression of very high-risk tumors. One of the reasons for that, and keep that in mind, is that the EAU risk classification doesn't, let's say, have a lot of patients treated with BCG. So that's not a realistic current way of treating patients. And Ashish has shown that actually the risk of tumor progression in these patients is much lower, so let's say around 15%. One of the other issues that you have to keep in mind, if you look at studies, some of the studies have taken as an endpoint that 40%, and because the real endpoint is much lower, then usually those studies take a long time to get their differences in treatments. So beware of the overestimation of progression if you use the EAU risk table. There's some more additional factors, and one of the things that is still not in any guideline, I'm really very surprised about that, is the T1 subclassification. There are numerous studies that have shown that the T1 subclassification is very important, and it makes sense. If you have a very small T1 just going into the muscle, or you have a very infiltrating T1, obviously there has to be a difference in prognosis, and it has been again shown in several studies. And another one which is coming up more and more, it's seen more and more by pathologists, is lymphovascular invasion. Very important risk factor, maybe one to decide to do a cystectomy, for example. What about intravesical therapy? Well, sometimes you don't have to do that, or you don't want to do that. And an office fulguration is in both guidelines now a, let's say, solid recommendation. You also can do active surveillance. For example, if you in follow-up see a small tumor, I sometimes do that. Or you do chemoablation. There is a very recent study, as you can see that the Envision study with the gel. You see that in 240 patients, well, the complete response rate at 3 months is quite nice. It's 80%. So that's maybe even just as good as a TOR, considering the 60% residual tumor that Ashish told us. And 82% of those patients remained tumor-free within 1 year. So something to consider. Low risk, I think that's obvious. We talked about that. It's a single post-op installation of chemotherapy, and you don't have to add a lot more. So no additional chemotherapy needed. I think that's a clear recommendation. It is effective. You see that. This is the SWOG trial. You see that's a very clear reduction in recurrence rate. In this case, let's say, is a hazard ratio of 0.53, so almost 50% reduction in low-grade tumors. And this is a nice trial. It's done with gemcitabine, and it's effective in reducing the 4-year recurrence rate. It's not always done. I realize that, not only in the US, but also in Europe. There are logistical problems. Maybe it's a daycare admission and patients go home quite rapidly, or there is a recovery room structure where it's not able to give chemotherapy. One of the reasons that you should not consider not giving chemotherapy is safety. You see in the SWOG trial, the number of patients having a grade 3 side effect is very, very, very small, actually almost absent. So it's really a safe way of treating those patients. Don't do that if you think you have perforation. Top on the right, that's a patient that had one single post-op installation, and he was sent to me with a persistent, very small bladder and a fistula. So for a TA low grade with one installation, we had to do a cystectomy. And if you are afraid of that perforation, you might consider post-operative saline or water continuous irrigation. It's a strong recommendation in the European guideline. Several studies have shown that it is effective in also reducing the recurrence rate. A small personal note, I don't use mitomycin C because that gives a lot of calcifications, as you probably all have seen. I use epirubicin, which is available in my country. Intermediate risk, also I think that's quite clear. Single post-op installation, and then you have to give a little bit more, or a course of induction chemotherapy and some surveillance, some maintenance, or 1 year of BCG. What to do, BCG or chemotherapy? Well, BCG is, of course, a little bit more effective, I guess, in intermediate risk tumors, but it also has more side effects. If you want to choose between these two, I think this is a very nice recommendation by the International Bladder Cancer Group. You see that if you have some of those factors, you see them here, makes sense, of course. If you have more tumors, bigger tumors, if they recur quite rapidly, if they recur more than that, and if you did have previous treatment, if you have more of those factors, the risk that you have a higher risk tumor is, of course, higher. So in this case, if you have no risk factors, basically it's a very low risk intermediate risk tumor, so you could only give a single post-op installation. If you have a lot of risk factors, do consider intravesical BCG. And this has been validated by SORIA, European Urology Oncology last year. You really see that with these risk factors, you can choose between these intermediate risk patients. You can really separate them in a little bit less high risk and a little bit more high risk. High risk, I think that's also quite obvious. It's BCG, and then according to the SWOG schedule, you have to give 3 years of maintenance BCG. But if you don't have that, so what should you do? Well, one of the things you can try is to give a little bit less. This is a very large EORTC trial, already a decade old, but still, it's a valuable study. And you see here, if you give the best, which is full dose for one, oops, sorry, wrong button, which is full dose for 3 years, or a little bit less, 1/3 dose for 3 years, full dose for 1 year, 1/3 dose for 1 year. You see that the toxicity and progression and cancer-specific mortality are exactly the same. The only thing that you sort of lose is some recurrences. So if you give less BCG and a shorter period, you will have a little bit more recurrences. In this case, it's around 10%, as you can see here, 54, 64% recurrence-free. So you can go down in schedule, in dose, and maybe in the number of treatments that you're going to give. However, you know that there are several strains around. You see here the development since 1925 until now. A lot of strains are available. This is a study where some strains were compared, and they were exactly the same, except if you would give 1/3 dose. You see here, I don't know whether that's really true, but in this study, 1/3 dose of Connaught had a little bit higher cancer-specific mortality. So do be careful with reducing your dose too much. Maybe that's not always a very wise idea. What to do with BCG relapse and salvage regimens? So, of course, your guideline says that you can do a second induction course, or you can go for one of those new therapies, trial enrollment, nadofaragene, gemdosi, or pembrolizumab. Those are some of the options that you can use. If you look at nadofaragene, this is a recent publication where you see that the high-grade recurrence-free survival is not really after 1 year, not very good. But, 50% cystectomy-free is okay. Over survival, that's also quite okay. So at 60 months, nadofaragene allowed, that was the conclusion of this article, around 50% of patients retaining their bladder. It's promoted a lot during this Congress, I see. I don't know whether it's used a lot. It's not used in Europe, of course, because it's not approved. Then you have gemdosi. You see a lot of articles about that. It has been used, as you can see here, versus BCG, where it apparently did a little bit better. It has been used in BCG failures, where you do have a very nice cancer-specific survival rate of 90% after 5 years. It has been used in BCG, naive high-risk patients. There are some trials going on. And if you use that, probably maintenance is also a good idea. I guess that's one of the regimens that's probably used a lot in America, also in Europe, if you have some BCG failures, or even if you don't have BCG. Future options, the superagonist N803, it's basically approved. It's very expensive, like I've been told. Durvalumab, atezolizumab, so the PD-L1 inhibitors. There was a very recent study about durvalumab published by a Greek group where they had some decent efficacy. The prolonged exposure, you probably also hear a lot about that during this congresses, the TAR-200, it's the gemcitabine and the 210 with immunotherapy. Thermosensitive gel, I just told you that. Now what I still use in my country is chemohyperthermia, quite effective also, if you have it available. Highest risk cystectomy, Ashish is going to talk about that. Treatment, taking home messages. So use risk groups to differentiate therapies in, of course, non-muscle invasive bladder cancer patients, and consider additional risk factors if you're confident with that. Single post-op installation is effective and safe and enough in low-risk patients. In intermediate-risk patients, use an adequate course of chemotherapy or 1 year of BCG and try to differentiate based on some of those risk factors. In high-risk patients or patients with CIS, use full dose 3-year maintenance BCG. And in high-risk patients, BCG-unresponsive patients, maybe something new, maybe a trial or cystectomy. And do keep track of all those new trials that are being done. Complications. This is a very nice, if you want to see something about complications, make a picture of this slide, and that will probably cover my whole lecture, from Koch et al. In Urology in 2021. It's a very nice manuscript about complications of intravesical therapy and what to do with that. Chemotherapy, the most disturbing effect of mitomycin is, of course, the skin allergy. If you have that, of course, you have to stop. You can't go on. Then you have, of course, some chemical cystitis, same with gemcitabine, no skin allergia, but also chemical cystitis in 20 to 40%. Neparubicin it's a very heavy molecule, twice as heavy as mitomycin C, has much less systemic toxicity, and also a little bit less bladder irritation and chemical cystitis. So again, that's one of the reasons that I usually use epirubicin. You see what you can do in all kind of situations with chemotherapy-induced bladder problems. Of course, you have to stop. You can give steroids, anti-emetic drugs, painkillers, alpha blockers. There are a lot of possibilities. Even do DMSO injections in the bladder or take away the ulcer. There are a lot of options. Please look at this manuscript. There is a lot of advice in there. BCG, local bladder problems, you see them actually quite often, around 95%, but they are usually grade 1 and 2. Serious adverse events like respiratory problems, urinary problems, genital problems, it's only fortunately in around 1%. A Danish registry has shown that very nicely. But in case of serious adverse events, we realize that the mortality is around 10%, which is, of course, a nasty problem. Symptoms decrease in the weeks after the installation, but they do increase during the 6-week course. So if you give the installation like we do on a Wednesday, Thursday is not good, the weekend is better, the next week it's good, but every new installation will give you a little bit more problems. The incidence of BCG infection after BCG installation, again, it's a Nordic study. It's again that approximately 1% BCG infections, so documented BCG infections, which I guess is a serious adverse event. The incidence was highest within the first 2 years, but they still see those problems after those 2 years, until 5 years. I was surprised about that. And apparently women had a really lower risk of having those infections. Don't know why, but apparently they are better off. So overall, the risk of a BCG infection after installations treatment, fortunately, is low, but if you have that again, there's a 10% mortality rate. How can you prevent that? Reduction of the dose, 1/3, half dose. Don't go too low. Stop maintenance earlier, so not 3 years, but maybe 2 years or 1.5 years. Decrease dwell time, maybe around 30 minutes. I've sometimes done that, and it does give you some additional effect. Shorten to 3 to 2 treatments per maintenance cycle. So normally you have in the SWOG schedule 3, you can always give 2. Antibiotic premedication, we already talked a little bit about that in the questions. There has been a very nice EORTC study combining BCG with INH. Didn't do anything, just more toxicity, because INH gives liver toxicity. You can give quinolones, but then specifically ofloxacin, and you give that the evening of the installation and the next morning. That's practically 6 and 18 hours. And it's also been seen with prodifloxacin. And there's a very recent review on this topic in European Urology, where it confirms that BCG side effects are a little bit less when you use quinolones. Apparently, you might have serious problems about quinolones, also has been recently documented. To be honest, I've never really seen that, but you can have some musculoskeletal pain, tendon rupture, neuropathy, CNS conditions. Again, apparently ciprofloxacin or quinolones have some serious side effects, but fortunately I've never seen that in my practice. How can you manage that? Of course, you can go for anticholinergic drugs or analgesics, and of course rule out a urinary tract infection because you are giving intravesical installation. You put in a catheter, you might have a simple urinary tract infection. And if it's more severe, stop of course the BCG, start the fluoroquinolone if stable with admission, start anti-tuberculous antibiotics, INH and rifapicin for 1 to 6 months if it's very severe. And in the worst case scenarios, if you have septic shock, really those patients have to be admitted, go to the ICU ward and have systemic corticosteroids. Fortunately, if you see at the trials that we are discussing a lot, the SWOG trial from 1985, the EORTC trial from 1996, you see in those trials that fortunately the toxicity profile is improving. Maybe because we know better now how to treat those patients with BCG and prevent side effects. Contraindications, of course, if you have a traumatic catheterization or you have hematuria, so the loss of mucosal integrity, and if you have an allergia. Relative contraindications are immunocompromised patients. So, for example, kidney transplant patients can have BCG, but of course you have to monitor them very well. And also prior tuberculosis, which we've seen, of course, a lot in Europe after the Second World War, is not a real contraindication for treatment with BCG. The take-home message for toxicity of intravesical therapy: know your side effect profile of the different drugs. If you look at chemotherapy, treat or prevent them with, where possible, and mitomycin C probably is the one with most side effects, especially the allergic reactions. BCG toxicity seems to be less severe and frequent than reported decades ago, but it can be life-threatening. Remind that. No one recognized symptoms, no treatment options, and know how to prevent or decrease these problems. Thank you very much.
I think we have a question for
please.
Is maintenance BCG for intermediate risk bladder cancer once a month for a year? Is it once a month for a year for intermediate risk?
It's not. Or do you want to answer that? Intermediate risk bladder cancer, and
if you've got a good indication to use BCG in intermediate risk, so with some extra, let's say, risk factors, I would go for 1 year, so that is 6-3-3-3.
Yeah, I think the question was, would you use monthly maintenance? And the answer is no.
Okay, because they talked about maintenance for intermediate risk bladder cancer. So what's your schedule then for maintenance for intermediate risk bladder cancer?
The same SWOG protocol, 6+3, because monthly maintenance has been studied and shown to have no benefit over induction alone. So don't do monthly maintenance for any risk category. It's the 6+3, even for intermediate risk, if you have enough BCG.
so the same schedule for the high risk, just that you only give it for a year instead of for up to 3 years.
Great, thank you.
So it's 3 doses for each maintenance.
And I'm glad you asked that question, because there have been older studies that used to do monthly maintenance. But when you look at the difference between doing monthly maintenance and induction alone, there's no benefit. So it doesn't work.
When do you give the BCG after resection, and what do you do with like post-resection calcifications, like related to dystrophic calcification or mitomycin? So when do you start the BCG and the calcification?
Well, usually, if you're going to start BCG, you mean like one instillation with mitomycin C? Well, I guess if you have had one instillation of mitomycin C, might give instillations and it might give calcification, then you decide on giving BCG. Fortunately, those calcifications are actually symptomless. So they disappear after 3 to 6 months, so the second cystoscopy, you don't see them again. And they don't give a lot of symptoms. I don't think that would influence my decision to give or not to give BCG.
I mean, sometimes you go back like every 3-6 months, they still have like big stones where you did the resection before.
I think it comes down to, is that symptomatic? So, I don't think the incidence of that is overly high, but certainly it happens. But then the question is the patient really symptomatic? And sometimes it's hard to differentiate while they're on intravesical therapy, is that lesion the cause or is it the intravesical? So I think one has to kind of, is it symptomatic? And if it's not, then I don't think...
Can I ask where you practice? Where? Okay, so in the US, right? Because what happened is about 8 years ago, the formulation of mitomycin in the US changed. It's no longer what used to be there 9+ years ago. So the current formulation of mitomycin, first of all, you can't get the 40 in 20. It doesn't dissolve. Secondly, it causes a lot more calcifications. So I don't know if you're still using it and seeing a lot more, but most of us have gone away from mitomycin because of that reason. And many people don't know that the formulation of mitomycin changed in the United States about 8 years ago. Even some pharmacists don't know that, but it makes it a lot harder for the patients to tolerate mitomycin, so we use gemcitabine. But I have seen patients refer to me with exactly what you're talking about in the current era with the mitomycin, and those stones don't go away unless you go in and resect them almost. It's just a crystal in there. So in those patients, if they're symptomatic, like Dr. Pohar said, I would remove them. Those just watch them. Yeah, the only problem there is, of course, if that's covering your prior T1 high-grade disease and you're letting T2 disease fester underneath, you don't know, right? So I don't like it when I'm not seeing the prior tumor site.
But most are asymptomatic.
Yeah, exactly.
Question?
Thank you very much for the talk. If you have a patient who is having T1 high-grade bladder cancer and he is immunocompromised due to renal transplantation, would you go for BCG, or if you have only BCG and mitomycin in your center, would you go? I know it's a relative contraindication, the BCG, but would you take a risk, or you give a mitomycin?
Well, basically, it's not an absolute contraindication to give BCG, like I told you. I've treated patients we have a kidney transplant center in my hospital, so I've treated them with BCG. To be honest, maybe now I would, for example, go for gemdosi, because of course you will have some risks if you give to immunocompromised patients BCG. Again, it's not a real contraindication, but I might skip now to gemdosi.
Yeah, I agree. I mean, for, again, medical legal reasons, I always get the transplant team to sort of sign off on using the BCG. But even then, if they sign off, the efficacy is likely to be lower because you're giving immune therapy to an immune-compromised patient. So we have gemdosi, and I use gemdosi. If you have single-agent mitomycin, you can use it, but it's going to be less effective.
You know, it's published in case series, and, you know, I have anecdotal experience. Again, we're a very large transplant center, and I've given BCG to several patients who are immunosuppressed from transplants. And so you have to work with your transplant team and, you know, obviously a lot of extra caution.
So BCG over mitomycin in this case?
Yes.
Yes, I would support that. Yeah.
Thank you.
So we're not supposed to give BCG in the setting of UTI. So what do you do with patients who have recurrent UTIs and you have to get them through the BCG? Do you have some preventative antibiotic? Do you just pre-treat them ahead of time? What do you do so they can get through this?
It's a question we get a lot, you know. So if I confirm a UTI, of course, give antibiotics, wait for 1 week, and then try to give BCG. If that's not possible, if I have to postpone for 2 weeks, I stop BCG and treat, of course, urinary tract infection, then do cystoscopy, see what happens.
Do you give them any preventative antibiotic? Or because they have to go through a series, you don't want to keep them canceling all the time, right?
No, I just give, let's say, ciprofloxacin for a week, which doesn't affect BCG nor negatively nor positively. And then if the symptoms have disappeared from the urinary tract infection, I will start the BCG again. Not if I have to postpone it for more than 2 weeks.
So the ciprofloxacin won't prevent the BCG from being effective?
No.
Actually, Fred, quinolone would, right?
Yeah,
because
so
you don't want to use a quinolone when you're giving BCG because it will kill the BCG bacteria. So you'd use a non-quinolone.
No, not all quinolones. Ciprofloxacin doesn't do anything.
In our center, in our hospital, it is. The BCG is, I mean, so it depends on your antibiogram in your hospital, but in our place, Cipro, Levaquin, all of them are listed in the anti-TB list. So I don't, maybe the strain you use, what strain do you use of BCG?
The Medac strain.
No, the Danish?
No, the Dutch.
The Dutch, yeah. So maybe it's a strain-specific thing, but Thais, it's sensitive to Cipro.
So what do you give?
Anything other than a quinolone, so Bactrim, anything other than quinolone, because the other antibiotics will not affect the BCG. But that's why most of these studies will give the quinolone 6 hours after the BCG, because you don't want to kill the BCG bacteria.
Right.
I wouldn't give, by the way, Cipro plus BCG. I give it for...
That's what she was asking.
No, I give it for 5 days, and if then the infection disappears, I'll start BCG. If it doesn't disappear, you might treat again, but I don't give ciprofloxacin during BCG treatment, just to prevent the infection.
And maybe just one small comment about that. I'm glad you brought that question up. That's a conundrum we all face, you know, not that uncommonly. So, often it's the strain of bacterium, it's a bacterial persistence issue. You know, there's not often changing of the strains or what you colonize in the bladder. And so you could consider putting them after a therapeutic course and eradicating it. You could put them on low-dose prophylaxis. And so, that's a strategy we've implemented at times, as opposed to every week, trying to treat an active infection, delay that week, get them ready for the next week. Try to put them on low-dose therapy because, it's the same bacterium, and you can often find a solution for that. Penicillins are often the organ. So it varies. I mean, you need culture data to decide what you're going to use, but certainly, penicillin, trimethoprim, sulfamethoxazole, whatever is appropriate. Next question.
Thank you for the talk. So in our hospital, we've got no access to BCG at all, so we can't use the low-dose regime you were describing. So can I just confirm whether you're using gemdosi in those patients? and what regime you use for high-risk non-muscle invasive bladder cancer.
Dr. do you want to answer that? So no BCG availability and a high-risk non-muscle invasive bladder cancer patient, what would you use alternatively?
Yeah, no, exactly. So in the U.S., because of the shortage, right, the de facto standard in those patients has become gemcitabine and docetaxel in places that don't have any BCG at all. And that's what you're saying. You have no BCG at all. You can't even give reduced dose. So that's become the de facto standard. And because it became the de facto standard, in order to study it, now there's a prospective randomized study, the BRIDGE trial, essentially studying BCG versus gemdosi to at least prove in a prospective manner that it's not inferior. I believe it's also going to open up in the UK, and Wen Shen Tan, who was one of my fellows and did a lot of work, actually has the ability and the funding to open up in the UK. So there's going to be UK series, US series. I suspect we're going to see that it's non-inferior at least, which is the endpoint, but we have to study it. But right now, if you don't have BCG, gemcitabine, docetaxel combo.
If I could ask, do you have access to gemcitabine, docetaxel, or are you limited by either of those agents?
Yeah, at the moment we don't have the dosi aspect, so I guess gemcitabine solitary on its own would be inferior. Am I right?
Dr. Richards, what do you think?
Where do you practice again?
What's that, sorry?
Where do you practice?
In New Zealand. So,
do you have access to hyperthermic chemotherapy? Because that's the other recommendation. If you don't have gemdosi, used enhanced chemotherapy and hyperthermic, and Dr. Witch has done a lot of work with hyperthermia.
We're in the process of getting gemdosi, so I think we'll go down that path. Thank you.
Thanks very much.
Well, some years ago, when we had the BCG shortage in the Netherlands, we only used gemcitabine because we didn't know or didn't have the combination gemcitabine and docetaxel. And also gemcitabine is a very effective drug. So that is a realistic alternative if you don't have BCG.
If I just summarize that for a moment. So we talked about the BCG, we talked about not being available. So I think the panel was kind of suggesting, gemcitabine, docetaxel would probably be the preferred agent amongst all of us. But if you don't have access to the docetaxel, single-dose chemotherapy then would probably be the next most appropriate step. Okay. Next question. Dr. Gordon.
How do you handle a patient with significant incomplete bladder emptying, or in particular a patient with diverticula, like case you presented?
Can you say that again over that applause? I think it distracted us a little bit.
How do you handle the patient with incomplete bladder emptying, or in particular a patient with the diverticula, like the case you presented? The concern that they're not going to be able to empty out the intravesical therapy?
What do you guys think about clamping the catheter, the safety of giving the drug, and to allow the drug to dwell appropriately? I think that's kind of where the conversation is going.
I'm more worried about once you give it, them being able to empty it out.
Empty it out. Well, my practical approach is you have to know the post-void residual. So, if you're concerned about inability for the patient to empty and they're retaining the drug too long, I think you need to document the post-void residual. And so if your residual is at an unacceptable level, you have a couple of strategies. You can keep them around. You can clamp the catheter, let it dwell and release it, or you could teach the patient CIC. But, that's a little complicated about drug exposure, drug discarding, how do you manage that then? How are you going to do that? Any other practical comments from?
Saying we measure residual urine before and also after the first instillation. And again, if that's not good, we leave in the catheter.
Yeah, and in those patients, one thing I definitely do is give them quinolones to take 6 hours after the BCG, because if they're going to retain some BCG in the bladder, the quinolone will kill the BCG and reduce that extra toxicity, and the cytokine peaks at about 6 to 8 hours, right? So that's a little thing I do. Do I have data? Absolutely not.
Okay, thank you.
Did that answer the question?
Yes, thank you.
Appreciate all the questions. This is good.
Hello, I'm Paolo Zeurito from San Raffaele Hospital in Milano. I want just to say that since the intermediate risk are a heterogeneous category, and the IBCG stratification system helps us to stratify these patients, they recommend to use BCG maintenance for patients with more than one risk factor. And I want to ask to the panel what's their point of view. If there are some intermediate risk patients with more than one IBCG risk factor that can benefit only from the induction. Since, this stratification is still not prospectively validated.
Did you?
Yeah, sure. I think the question was the International Bladder Cancer Group, which again, Dr. Witches, myself, and a few others had founded in 2006, and now it's got more than 100 members all across the globe. It's an expert-based recommendation body, right? Our goal is to try to develop guidelines to help people in underdeveloped countries as well as North America and Europe. So that was consensus-based as to how we can de-intensify treatment for patients that have no risk factors. Don't give them too much treatment. And patients that have 3 or more risk factors, consider them high risk, right? So that was to kind of like help separate out the extremes. And in between, you can choose chemo or BCG. So it's not that you have to do BCG. Now, that was purely expert opinion. It has been validated in other series, including from Milan, from Rome, from other places, as to it helping not only active surveillance, but these patients. But do we have a prospective randomized study for it? No.
So there'll be a slide as we walk through the case here. So what Dr. Kamat was just talking about, I have a slide on that IBCG recommendation. So if some had some difficulty following the conversation, we'll have some brief comment about that.
Yeah, just a question on a case I did recently. About a 2.5, 3 centimeter tumor, superior and lateral to the left UO. I used a Collins knife and did an en bloc resection of the tumor, removed it. UO looked like it was fine. He ended up developing a stricture. I guess the cautery artifact got it. I put in a stent. I took it out, it again restrictured. I put in a stent back. This took a little bit of time. I had re-resected the tumor bed. No tumor, but he had some small satellite lesions on the dome probably from the initial resection. He's healing with the stent right now, but I wanted to give him BCG, but obviously the UAs aren't going to look right with the stent in place. Suggestions, do I put a nephrostomy tube, take out the stent and give it, or other treatment options?
No, you can give BCG with a stent in place. Just check the UA if he's asymptomatic. I mean, don't worry about...
It just keeps showing with blood with the stent in. Do you still just give it anyway?
So long as he doesn't have gross hematuria or frank infection, a stent is not a contraindication to BCG.
Yeah, I think that was a good practical thing you brought up at the end, is that if the patient has ongoing hematuria, intermittent or not, from that stent, then you have no choice but to kind of maybe put the neph tube in. But generally, without hematuria, I think there's any lack of evidence that even if some of the drug refluxes into the upper tract that we really know that reduces efficacy? No. So I think it's very appropriate to give it in the context of a stent. Hopefully, though, you can move on with an endoureterotomy at some point down the road and get that situation resolved.
Thank you.
In fact, just to follow up on that, right, if patients have high-grade tumors in the distal ureter, intramural ureter, oftentimes you will resect the UO to let it reflux so that the BCG kind of trickles up. So that's something we do on purpose. And there are some places that will actually give BCG with a retrograde stent put up all the way in the kidney. So even if it refluxes, it's not going to cause any harm.
I was just worried about the BCG sepsis, just trying to be so cautious.
If you're that worried, the one thing that I do sometimes, start with a lower dose of BCG, make sure patient tolerates it, and then go to full dose.
Very good. Thank you.
Okay, one more question. Dr. Petros.
It's a comment here. I want to show a raised hand from the panel. If you have a tumor close to or involving even the UO and you resect the UO, are you typically in your practice, you leave a stent? You don't leave a stent if you see the UO refluxing nicely after? And what is that theoretical risk of seeding of upper tract when you just resect a tumor in the bladder?
So I don't
expect going to be high grade.
So if the tumor is right at the UO, and obviously I'll do a ureteroscopy to confirm that there's no residual tumor more upstream. I won't rely on urography exclusively in that setting if there's tumor clearly within the UO. I don't routinely leave a stent, but if the tumor's back in the intramural tunnel and you're cutting pretty deep into the wall of the bladder, then I certainly will stent that patient. And at that point, I'm not willing to do a ureteroscopy at that time. I'll bring them back when everything heals and that UO is much more mature and patent, and ureteroscopy becomes very straightforward again. So that's my own approach.
Yeah, I don't remember the last time I've left a stent in for even that indication. The thing is, I use bipolar. There's less charring. I make sure I can see mucosa of the UO, like the ureteral mucosa should be visible. If I don't see healthy ureteral mucosa, I will have them give the patient 10 of Lasix on the table to get that peristalsis going. And if I don't see mucosa protruding out, I'll resect some more. Now, if I don't see any of this, which hasn't happened, I can't remember almost in 10 years, then I would potentially put up a stent. But haven't put up a stent, haven't had any strictures, I don't do it.
You might be obligated to follow that upper tract. That's a judgment thing by ultrasound or some. There is a. It's published. There's about maybe a 3 to 5% rate that there will be a silent obstruction and hydronephrosis of that unilateral tract. So you probably have some obligation to follow that track that you don't develop silent hydro and potential unrecognized obstruction.
Oh, yeah, good point. I mean, all those patients get an ultrasound. You know this. You trained with me. They all get an ultrasound when they come back to start their therapy and confirm no hydro.
Okay, we'll go back to that case. Appreciate all the questions. This is great. Okay, so if we recall the case, thanks for the slides again, being ready there. Appreciate that. So this was the case of the diverticulum, the high-grade TA. We talked about, essentially, there was consensus that we wouldn't do a diverticulectomy. So let's follow up on some of Dr. Witch's talk. Let's keep building concepts. Patient received full-dose induction BCG therapy with limited local toxicities. First follow-up cysto at 3 months was normal. Urine cytology was reported as atypical urothelial cells. He completed 1 course of full-dose maintenance BCG. Did good, again, with limited local toxicity. Second follow-up cystoscopy at 6 months was once again normal, but urine cytology was no longer atypical, was now suspicious for high-grade urothelial cancer. I'm just going to, before we kind of ask about next step in management, I think I just want to emphasize that we're all aware of the Paris system for reporting urinary cytology. The system was implemented in 2016 and underwent a recent revision. It's called the TPS, the Paris system. How many in the room are familiar with this and feel like your cytopathologist or the pathology group that you use to report your urine specimens, do they use the Paris system? Have you heard the terminology? I see a lot of, can we raise hands? Who's familiar with it? Oh, that's terrific. So pretty large consensus. So, bless you. So there was the first iteration, and the purpose of this, the purpose of this system, prior to implementation of the system, you could get so many different reports, a lot of reporting of terminology that was very diverse and a lot of inter-observer variability of the specimen. So the main effort was to synthesize how you report the cytology, looking at objective criteria like nuclear cytoplasmic ratio, hyperchromasia, nuclear bodies, and also to reduce that category of atypical urothelial cells. That varied from 20 to 50%. And the updated edition demonstrates it's now been reduced to 5 to 15% of reports in the United States. So it's really achieved its effort. So I'm glad we know about that. Okay, so Dr. Witches, would you use a urinary biomarker to adjudicate the atypical at 3 months? When there were atypical urothelial cells, would you use a biomarker to adjudicate whether you would pursue that any further?
I don't use cytology anymore.
You don't use cytology?
No, I only use a biomarker.
You only use, what biomarker do you use?
We use the EpiCheck.
EpiCheck. Anyone in the audience moved on to a urinary biomarker for standard surveillance cystoscopy? This is a good point and a good point of discussion. And I have the AUA guideline statement up there. Anyone use a urinary biomarker exclusively instead of cytology? How about in conjunction with the cytology routinely? I see a couple of hands. I don't. I use cytology. Dr. Kamet?
Cytology, yeah, absolutely. I mean, our guidelines state that, and none of the current markers have reached that level of confidence, at least in the United States, for us to replace cytology. We'll use it as a reflex, as you showed here. So if it's atypical and you want to adjudicate that, then again, we use Eurovision FISH, but then you can use a marker. So I haven't replaced cytology.
Dr. Witches, do you want to give your comment about in Europe or in the Netherlands about using EpiCheck? So certainly that's not the AUA guideline.
No, well, there is, in next month, there is an article on a marker study in European Urology. I wrote an editorial, and the title is that we should change the guidelines, really. Anyway, so in the Netherlands, it's now reimbursed.
Okay, so we'll wait. Well, we're anxious to see the publication. So this might be good knowledge, and we may have to alter some discussion in the course next year. So this is good.
Well, let's be honest, I realize that the problem with markers is, of course, the financial aspect, because you can't do a cystoscopy, which usually earns some money. You have to buy a marker. So I realize that there are some, let's say, logistical or financial problems in using a marker. But in all, if I would have to have a cystoscopy, give me a marker, don't do a cystoscopy.
But I think, Kamal, just to clarify Fred, and Fred knows a lot about bladder cancer, he uses the marker sometimes in place of cystoscopy. That wasn't your question. Your question was in patients that have cystoscopy and cytology, would you always use a marker? Just to clarify for the audience.
Okay, so we'll just kind of take a step back. So to adjudicate atypical urothelial cells, I think the very nice thing is the Paris consensus classification has reduced that category to, we don't see that very often, 5 to 15%. The likelihood of finding cancer in that patient, if you further evaluate them in the operating room, is very unlikely. So the AUA guideline statement you see there about adjudicating an atypical urothelial cytology. How about a suspicious cytology? Would you need to adjudicate that or take them right to the operating room? Dr. Kamat, operating room or use a urinary biomarker for suspicious urinary cytology?
So that's where you really need to know what your cytopathologist is doing, right? Because some cytopathologists will say suspicious for anything that looks abnormal, but if they are following the Paris classification, they would usually report suspicious for what? And if they say suspicious for high-grade urothelial carcinoma, those patients, depending on their risk factors, deserve an evaluation.
Would everybody take this patient to the operating room or use a biomarker to try to prevent that? Who would take them to the operating room? Who wouldn't? Those who wouldn't, does someone want to make a comment at the mic? What would you do instead? Dr. Petros, do you mind?
If atypia, I will not act on it. If
so how about suspicious?
Suspicious, yeah, I would take him to the operating room.
Okay.
But if atypia, not.
Okay, so that's the scenario here at 6 months. The patient has a suspicious urinary cytology.
Kamal, one more question.
So how about repeating a cytology? Many times I repeat a voided cytology. I mean, this is a cytology cystoscopic, very likely. I have done it in my practice. You repeat a cytology voided a few weeks down the line, and it's fine. Go back to square one, it's all clear, and then we can follow as we were supposed to follow. I've done this.
Yeah, that's a reasonable strategy for atypia.
Yeah, I think for atypia, but for suspicious, we'll put a report of high-grade urothelial cancer, a positive cytology. I think we can all agree we probably wouldn't repeat it in that setting. How about for suspicious urothelial cancer? Would you consider repeating it?
Not if it's suspicious. I mean, because my cytopathology essentially is telling me that is positive. That's what they're telling me. So you need to know what they mean by that.
And I think what Kamal says, as she said, it depends on the history of the patient. If he has had a low-grade TA and you get that cytology, I would probably repeat it. If he has had, like in this patient, a high-grade tumor, I think you would go for a cystoscopy or for the OR.
Yeah, because I think, again, if we look at the sensitivity of analysis of a suspicious cytology, how often you will end up detecting cancer, it's high. It's over 80% likelihood that you will find cancer on that evaluation. Now, obviously, if a patient, if in a practical setting, if the patient is very reluctant to have an operative procedure, sure, repeating it in that setting, if it's suspicious, I mean, that may help continue that conversation towards the operating room. Question?
At this point, do you consider to look at the upper tract?
Yeah, I think it's important. And so I think there's different, you could do a CT, you could do urography in advance with cross-sectional imaging, or you could evaluate that in the operating room. For the sake of time, you know what I think I'm going to do, I want to bring Dr. Kamat up to the stage to present his talk to us. And then I have another case that I want to present after that. So I think I'll kind of move on from this case, but I'm just going to bring up a clinical conundrum that happens commonly, and I want to bring the panel in. So I'm just going to jump forward here. I'm going to gloss over the details. The patient went to the operating room, was evaluated for this suspicious cytology with enhanced cystoscopy. There were really no findings that were identified by blue light cystoscopy or white light. Some random biopsies are done. Retrograde pyelograms are done. We don't see anything, but barbotage is done of collecting urine from the upper tracts, and one of the upper tracts is now suspicious for urothelial cancer cells on from the left renal pelvis. So what do you guys think? Urography is negative. You don't find anything in the bladder or prostate. They're biopsied. They're negative. Now what? Dr. Witches, now what's going to happen?
Well, if you think there's something in the left system, I would go in, take biopsies.
So ureteroscopy. Yep. Okay. Dr. Komet?
Yeah, I agree.
Okay. So ureteroscopy is done. It's negative. You collect the cytology at ureteroscopy. You don't see anything that you can biopsy. Nothing looks like it needs to be biopsied. You collect a cytology from there. It's suspicious again. Dr. Witches, now what?
Well, if you haven't got you don't have a target, so I would go on with intravesical therapy.
You would do it. You would give.
I think he still is on BCG.
He's on intravesical BCG for.
We'll go on.
Continue with his maintenance therapy. Dr. Komet, what about that upper tract?
I would not treat somebody's upper tract for just a suspicious cytology. So I would not start putting nephrostomy tubes or anything like that, but I would obviously know that I have to monitor that carefully.
Yeah. So obviously diligence. Who would monitor that by follow-up ureteroscopies? Raise of hands. Okay, about half the room. How would, and then how about we'll just follow up with urography, CT urogram? Half the room. I think both approaches are very acceptable. Yeah. Great. Okay, I'm not going to present this case. If we could please bring up Dr. Kamat's slides.
One quick question.
Yeah. Oh, great.
For that patient, for follow-up, like is their I feel like oftentimes their cytology will continue to be suspicious. At what point do you take them back to the operating room for to do that whole evaluation again, or do you suspect, okay, CTU's negative, clinic cysto's negative. We know that the positive cytology or the suspicious cytology from the left renal system is just a cytology. At what point do you go back to the OR for like a
Yeah, I think that's very practical. So I think if you're not following by ureteroscopy for a period of time, and then maybe you switch to urography when you're not finding anything, or the reverse, if you continue to get, you may be obligated to go look, because urography sensitivity is less than that of ureteroscopy. So, it's potential tumors developing in that upper tract, and, if that persists, that would be my approach. But in this patient, I actually followed them with semi-annual ureteroscopy for a year, and we didn't see anything, and then I switched him to urography. But his cytology, as you brought up, continued to remain positive on and off. And we couldn't find anything in the bladder.
Use a marker.
Yeah, I was just going to say, in that situation, even though Eurovision and all these others have not actually, they've been looked at in the upper tract, but they have not been validated in the upper tract, right? I would, in this case, use a marker to give me confidence that I cannot have to continue to keep looking up. If the marker, for example, Eurovision shows when you look at 25 cells, there's 17 cells that are lighting up with genetic abnormalities, then I'm worried. Then I don't think it's suspicious. Then I think the cytology is positive, right? And in that situation, again, talk to the patient, share decision-making, all that stuff. If you suspect there's CIS or something hiding up in the upper tract and the patient wants to be treated, I will, in that situation, persistently positive, markers getting worse, I'm just not seeing anything, I might actually treat the patient's upper tract with something.
Meaning BCG?
Yeah.
Would any of you guys ever do a neph or a U for CIS?
No.
Yeah, I wouldn't do a neph for you, but BCG through a nephrostomy tube, or put a stent in, or retrograde catheter?
So we've done it both ways, and again, that's the thing. The efficacy is the same. I talk to the patient. A lot of patients say, well, just put the tube in, leave it in for 6 weeks, I'm fine with it. Some patients hate that idea, and they come in once a week, and you put the retrograde catheter and give BCG that way.
Many in the audience treated upper tract cytology findings or documented CIS on biopsy with intercavitary BCG, either through a neph tube or how common practice is that? Anyone treating upper tract carcinoma in situ with BCG? I see some hands going. Yeah, it's a stressful situation, I would say, personally, from a clinical perspective. It's kind of one of these situations where you're trying to do everything you can to save that upper tract, and it can be a conundrum. Okay, let's put up Dr. Kamat's slides. Appreciate it.
So I have to say, Kamal, really impressed with the audience, with the questions and the insights and stuff like that. And obviously, a lot of what, not a lot, but some of what I'm going to cover has already been asked in some of the discussions. Essentially, what I'm going to cover is when do you not want to miss that window of opportunity for cure for your patient with non-muscle invasive bladder cancer, and what are some of the options that we have today as of 2025 right now at the AUA for those patients. So the bottom line is always keep in mind at every stage that you're checking your patient, make sure that you're not missing the window of opportunity for cure, right? And when would you miss that window of opportunity for cure? So there are a few factors where you consider this patient to be extremely high risk, even though they have non-muscle invasive bladder cancer, for actually harboring worse disease than you think that it is. These are situations where, yes, it might be classified as non-muscle invasive bladder cancer, but these patients could actually have metastatic disease even without undergoing that stage from T1 to T2, essentially. And the first group is that very high-risk category that Fred talked about in the EAU guidelines. So these are patients with T1 high-grade bladder cancer, CIS, T1B, where they're deep, as he showed, prostatic urethral involvement, et cetera, And I put up this slide periodically just as a reminder to everyone that T1 high-grade bladder cancer is not a superficial tumor. It's already invasive. It's just not invasive into the muscularis propria. And if you actually put this in nomograms, the risk of dying from T1 high-grade bladder cancer is the same as a prostate cancer patient with T3B disease, Gleason 10, all-cause positive, PSA 75. And you clearly would not think of that patient as someone that has non-significant disease, right? So that's what you want to keep in mind. And for T1 high-grade bladder cancer patients, in the appropriate setting, all the data suggests that if you do a cystectomy early, you have better results for your patients. So keep that in mind, counsel the patient. Not all patients want to go on for early cystectomy, although it surprised a lot of us, and I was part of the study, and Kamal, I might ask you just to comment on it. John Gore presented the data from the prospective patient-reported outcomes of the CYSTO study, where patients were given the option of sparing their bladder, and this was after BCG did not work, or going on to radical cystectomy, and they reported their patient-reported outcomes. The quality of life was better financially, emotionally, and economically with patients who underwent radical cystectomy up front. But even in those who underwent radical cystectomy, the quality of life initially dropped for the first 3 months, but after that, patients reported they had better quality of life without their bladder than with their bladder in place, with the knowledge that they still had cancer. Kamal, what do you think about that? Do you think that's going to change how we counsel patients?
Dr. Kamad is referencing this, a very important pragmatic trial that got presented here at the meeting in one of the plenary sessions. And I think it's an additional layer of information that is going to be very instructive to counseling patients about our trepidation about cystectomy and how it might impact their quality of life. Now, certainly there's complications with the surgery. There's a potential risk of mortality that you have to bring into the equation when you compare it to bladder sparing. But when you look at the purity of quality of life, that trial is incredibly eye-opening, that patient-reported data, quality of life is very good after radical cystectomy, whether you have a conduit or a continent diversion.
Yeah, I mean, that was again, surprising to a lot of us in the room, or even before when we saw the data before it was presented. The second group of patients that have non-invasive disease, and you should be thinking of early cystectomy, is those that have lymphovascular invasion. And essentially, you look at systematic reviews, single center, whatever it is, the aggregate of data essentially shows that patients with lymphovascular invasion on their TURBT have a risk of having node-positive disease, even with T1, even though it's not T2, and some even with TA if they have LVI, which is a rare occurrence, so you want to make sure it's not an artifact, will have an incidence of having node-positive disease with non-muscle invasive bladder cancer. So these patients clearly do better with a radical cystectomy. If I could ask Dr. Witches real quick, with patients that have T1 and LVI, are you going straight to radical cystectomy? Are you offering BCG, or are you actually considering neoadjuvant chemo followed by cystectomy?
I would have a good conversation with my patient aiming at cystectomy, but of course, if they don't want, you would do something else. But lymphovascular invasion is not good.
Yeah, and again, it's shared decision-making. A lot of patients would say, I will still want to try something, but you have to monitor the nodes. And those are patients in whom I will get more frequent imaging, right? You don't need to do CT scans in patients all the time, but LVI, T1 disease, you're trying to spare the bladder, you need to make sure that the lymph node basin is imaged when you have these patients surveilled. Now, histologic subtypes are something, again, that have gained more recognition in the last 15-ish years. Back in early 2003, you barely had these histologic subtypes reported in pathology reports. They were less than 1%. Now it's close to 10%. So 1 in 10 patients that you see will have histologic subtypes. And essentially what the AUA says, in patients with variant histology, consider initial radical cystectomy. And if you don't do an initial radical cystectomy, just restage the patient and make sure that there's nothing worse going on. And a lot of this is based on data from initial small single-center studies, such as this from MD Anderson that we published back in 2006. But you can see that in patients with micropapillary disease, a large percentage of these patients recur, but more important, a large percent progress, including to metastatic disease when you give them BCG. And because of that, and Dr. Witches, I think you were a lead on this, a very high consensus statement from the ESMO consensus is that if you have T1 high-grade disease with micropapillary histology, essentially treat these patients with initial radical cystectomy and lymphadenectomy, and the consensus was 86% agreed with that recommendation. And this is just a flow chart for you to help sort of like visualize and contextualize. Not all histologic subtypes are the same. So if a patient has squamous differentiation or glandular differentiation, that's not a reason to take out the bladder. That just means that that tumor is a little bit more higher risk, and you have to consider that a higher risk within the high-risk category. But if they have sarcomatoid, plasmacytoid, micropapillary, clearly they're not going to do well with intravesical therapy. If they have small cell, don't go to radical cystectomy, treat them with chemo first, because even though it's found in the bladder, we have to think of small cell carcinoma as a systemic disease that you just found in the bladder before you find it somewhere else. And of course, patients that have pure squamous or pure adeno are a different beast, and they do much better with radical cystectomy than BCG. Now, the last category is patients.
Yes. What's your cutoff for the percentage of histological subtypes?
Yeah, that's a very important question. So what Dr. Witches is asking is if you have, say, 10% histologic variant in the tumor, or you have 50% or 100%, does that change what you do? Absolutely. For those within the micropapillary and the others there that I showed you, but not for those that have small cells. So any small cell, treat it like 100%, but if your pathologist says there's a little bit of micropapillary, it's mainly urothelial, those patients, you can tell them, yes, you do have a micropapillary disease in your tumor, but it's such small amount that if you want to try to save the bladder, let's try that, because it can work. BCG can work in those patients. So the last category essentially is those that have BCG-unresponsive disease. And again, we all know in contemporary series, BCG works really well. This is data from our center, and in contrast to what was reported 8, 10, 15 years ago, where BCG doesn't really work too well, you can see, and Fred alluded to this, the response with BCG nowadays, even in that high-risk category, it's single-digit progression numbers, right? So BCG works really, really well if you give it properly, 6+3. But it doesn't work in some patients. And if it doesn't work in some patients, there's a whole sort of variance in definition as to what that means. So a little bit of a history lesson here. We all know that BCG was first used in the bladder at the NCI in 1970 and then quickly went away. And then it had a resurgence when Alvaro Morales and Don Lam used it and was approved for intravesical therapy in 1990. There was a dearth of approved agents after that till about 1998 when you had valrubicin. It was approved with really poor response rates, right? And because of that, afterwards, there was really nothing approved. And the AUA and other groups, the International Bladder Cancer Group, again, Fred, you're a co-author on that, came together, advised the FDA, and the FDA came up and adopted this definition in 2016, published it in 2018 for BCG-unresponsive disease. So what is BCG-unresponsive disease? This is a clinical trial definition, and I want to make that emphasis. This was never a definition put forward to have us make decisions in the clinic. It was purely a definition that was put forward so that the FDA would allow investigators, pharmaceutical companies, to do single-arm studies and call that single-arm study a registrational trial. So patients have to have had at least 6 weeks of BCG and 1 attempt at maintenance or reinduction, and then if they had these criteria, they were BCG-unresponsive. So those are the BCG-unresponsive patients that you see listed in all these trials that are coming out. And of course, once the FDA adopted that, there was an explosion of clinical trials. Pembrolizumab was approved in 2019, nadofaragene was approved in 2022, and we saw some updated results from nadofaragene here. NAI was approved just last year, 2 days before the AUA in 2024. And of course, we have a whole slew of other drugs that are currently being studied, CG, Engine, TAR-200, et cetera, and we're all waiting, and we expect that these will be approved, right? But when you have so many drugs that are approved or potentially going to be approved, what do we do with these drugs? How do we help our patients? How do we sequence? What do we think about that? So again, that's a conundrum that faces all of us, and because of that, we as a group came together and actually had a full 2-day sort of think tank retreat on how do we sequence these drugs, what's the recommendation, what do we practically do in the clinic for patients who are BCG unresponsive. So this is all in that paper, and I'm obviously not going to go through every little detail, but the first thing we have to do, and again, you've heard this from Dr. Pohar and Dr. Witches, every time a patient comes to you and they have a recurrence and they're looking to do something other than a radical cystectomy, make sure that it's safe. So look at the prostatic urethra, do your blue light, look at the upper tracts if you need to, do your imaging, make sure that it's safe, because you don't want to miss the opportunity for cure. It should be your dictum that no patient that comes to you with non-muscle invasive bladder cancer should ever die of their disease, right? If you let them become T2 or more, it should be our fault. It's not that patient's fault. That patient trusted you when they came to you with non-muscle invasive disease. So make sure that you actually do that. And if the patient is suitable for bladder-sparing therapy, then you can talk about what to do when the patient has CIS, plus or minus papillary disease, or papillary disease. So, and I think I see Dr. Narayan at the back there that has done a lot of the follow-up work in nadofaragene over here, and I'm glad he's over there, so I'm sure he's going to ask some questions. So patients that have CIS plus or minus papillary, the current recommendation in the US, other than a clinical trial, is to use gemcitabine and docetaxel because it works well, it's cheap, it's available, and it has sufficient data to make that a recommendation in the clinic, right? What we should do. Approved drugs, however, nadofaragene is the approved drug that is recommended in that situation. NAI plus BCG comes second, not because the efficacy is lower, but because the cost is extremely high. And in some healthcare systems, for example, because of the cost of the drug, the healthcare system will not allow you to use NAI plus BCG unless you have already tried Adstiladrin or nadofaragene. Kamal, can I ask you, at your institution, will your pharmacist or your PTC, which is the committee that looks at cost, allow you to use NAI without trying something first?
Yes, we're allowed to do that.
Yeah, so there are some where you can, and at our place, for example, at MD Anderson, we're essentially told, and I think it makes sense, because it's $1 million a year, that you can't use it unless you try something else first, and it's a cost issue. And of course, pembrolizumab, even though it was the first to be approved, has a lot of systemic side effects. So patients usually don't want that, and we don't recommend that unless you don't have any other option and the patient's refusing a radical cystectomy. It's a little different with papillary disease. So if the patient has Ta/T1 disease, there it's a little bit different as to what agent we recommend and in what order. So gemcitabine and docetaxel, and again, you heard Dr. Witches talk about it, really is still the first recommendation outside a clinical trial. If that's not something that's feasible, that's not something that the patient wants, or the patient says, hey, I only want to try FDA-approved drugs, then the primary recommendation there is nadofaragene. If you don't have nadofaragene, or if you want to go on to something else, hypothermic chemotherapy. Now, in the US, we don't have hypothermic chemotherapy, so we can't use it here, but the preponderance of data from international sites suggests that this is a very reasonable option. You can then also go on to single agent chemotherapy in this patient that has papillary-only disease, and that was a question that was asked earlier. Can I use gemcitabine alone? Yes, you can, but it's lower down on the list of recommendations. And again, purely because of cost, not because of efficacy, because NAI plus BCG really works really well, but is extremely expensive. The recommendation is to try that a little bit later. And of course, pembrolizumab is listed there. Most patients don't want to have it because of its side effects. So putting all this into context, and again, this is all in the manuscript. Please go to the manuscript. Don't try to take a screenshot. I can't see this with my eyes. I don't think you'll be able to see it with the pictures over there. But it's all in the manuscript, and the manuscript is freely available. So now, putting all this into context, right, when we're trying to counsel patients, this group out of Boston did a very nice job. They essentially put these drugs that we currently have available on this little graph here. And you can see the historic control is the results of the valrubicin that I showed you earlier. The other line, the BCG line, is what we had recommended as the minimum bar that a drug has to meet for it to be clinically meaningful, right? So when you put these drugs in there, you can see that the only regimen that actually surpasses that bar is gemcitabine and docetaxel. The others come close, right? They hit the bar, they come close, they overlap, but the only one today, even though we have these drugs that are being studied and approved that crosses that bar, is gemcitabine and docetaxel. That's not to say that we don't hope and expect that the drugs that are being looked at right now, whether it's TAR-200, CG's drug, Engene, will surpass that bar. And even with nataferigine, remember in the trial, they were not allowed to do reinduction, which has evolved over time. So they are studying reinduction. So it might be that those do cross the bar, but this is the data as shown in this publication from a group out of Boston. Now again, we have to keep the patient at the forefront of everything that we do, and patients always have questions to you about, am I giving up short-term cure for long-term cure for short-term gain? What about the cost? I just don't want to have multiple cystoscopies, et cetera, et cetera. And I think this is what is at the forefront of every patient's mind, right? Am I giving up long-term cure for short-term gain? And the answer, and we looked at this in retrospective sort of pooled analysis, it's been looked at in other analyses as well. This is from MD Anderson, Dr. Tan published this. The results with patients who go on to get bladder-sparing therapy or delayed cystectomy in today's day and age, right? It's not the same as previously, but today with blue light, with us resecting tumors, being more diligent, there's no difference in survival so long as you're being diligent and staging the patient at each point to make sure you don't miss muscle-invasive disease. And it's not just MD Anderson, but this is a pooled series, the IBCG series that AUA2025 put together and has led, that shows that even in multi-center pooled analyses, patients actually do fairly well if you offer them bladder-sparing therapy and not necessarily upfront radical cystectomy. If you put in the numbers there, actually, you can see that the metastases and death all the way up to 5 years is extremely low in these patients. Now, it's not zero, and I did say earlier, we don't want our patients to die of their cancer, but if you tell a patient that you have an 83% chance that you will be alive with your bladder intact and no metastases at 60 months, I think a lot of patients, especially older patients, will like that. And we, again, have to balance that with the conundrum of the information that came out, again, at this AUA, where radical cystectomy is not as bad quality-wise, right? So this is everything that makes it, sort of an art and the way of talking to patients and counseling them. And with that, I want to thank you for your attention.
I was just going to emphasize, the faculty on the panel were very willing to share all of our slides are in the course materials. So I see a number of you taking pictures of the slides, but you also have access to them in the course materials. So our slides are there if you want to reference some of these really important papers. We're a little bit tight for time, and so what I think I'm going to do, we have 10 minutes, and I'm going to go back to Pohar's slide deck 2, the one I passed over. If we could go to that one. That's a case on intermediate risk. I think Dr. Kamat did such a good job of this BCG-unresponsive space, outlining the options and just balancing, how do you make decisions safely in a patient, and balancing factors of patient age, travel, what's the cost of the drug, what's their current bladder function, how would you choose nadofaragene versus IL-15, where does pembrolizumab come into it? So that was a case I had, but I think we've had enough conversation around that. And we brought up the cysto study demonstrating that radical cystectomy outcomes in terms of how patients perceive their quality of life is better in many endpoints when you compare it to bladder sparing. And so it's something that we're going to factor in when we talk to patients and understand that piece better. In this case too, because we're a little pressed for time, I'm going to kind of gloss over it. I'm just going to get to the practical management of a patient. And so I'm just kind of really skim over the clinical details. So I hope that's okay with everyone. So this is, let me go right to case 2. Here we go. Okay, this is a healthy lady, has papillary tumors. They're completely resected. They're low-grade TA. So she's intermediate risk, non-muscle invasive bladder cancer. And we did have a question from the floor earlier when we were talking about, would you give the patient BCG? Would you give the patient chemotherapy? We alluded to the International Bladder Cancer Group criteria and factors that can maybe make that decision. And so here's the table from the paper, and kind of looking at the risk factors that predict for recurrence in that individual, the number of tumors, size of tumor, prior recurrence rates, have they received previous intravesical therapy. And essentially, we would advocate that most patients should get intravesical chemotherapy. But there is a higher risk group of patients who failed prior chemotherapy or who have more substantial risk factors of number of tumors, recurrence rate, size of tumors, where you would consider BCG. So I'm just going to kind of move on from that. The patient that I presented, we gave chemotherapy. And you have options, whether that's mitomycin, gemcitabine, what other therapeutic agent you're going to use. In Europe, you might use a different agent. And she did well, but then she recurred a year later with small volume papillary tumors. So known low-grade history, recurs with small volume papillary tumors. And I want to bring up some modern management, maybe not so modern, but the data is building. From the panel, who would put her on active surveillance? Those small tumors, cystoscopy shows you 2 small tumors, less than a centimeter in size, cytology is negative. Who would put her on, would suggest observation or active surveillance as a very reasonable strategy?
I would discuss it with her at least.
Would you advocate for it? As often the patient will say, would want to hear from you, and often would go with your advice.
What was the age?
54.
She'll probably have a number of TORs in the future, so I'd probably go for active surveillance.
Dr. Kamat, what do you think about that?
Yeah, no, I think that's a good point that Fred made, right? Because if you resect these tumors, you're sort of setting that mindset in the patient's mind. So I will discuss active surveillance of the patient. And oftentimes these patients, once they see that you can watch these tumors, and these 2 tumors can sometimes stay 2 for 5 years, right? And they just don't change. It's a different mindset than going back in every time to resect these tumors. That being said, you have to make sure that they're not high grades, right? So there should be no, send to cytology, make sure it's negative, make sure there's no gross hematuria, they shouldn't be symptomatic. You want to make sure you've looked at the rest of the bladder carefully. But if they're 2 smaller tumors and they're tiny, we and others have shown that it's very safe to do active surveillance. If the patient's a little bit nervous, you want to cauterize in the office, that's fine too. But I try to avoid going to the OR repeatedly for these small tumors unless they get to a point. And you should each have your own trigger as to when you come off active surveillance. But I have my triggers, and then I come off of it. Now, again, if the patient's anxious, I'll take him to the OR.
Yeah, I could certainly say this is growing in my practice, the number of patients I'm observing. Raise of hands, how many advocate for observing these low-grade tumors, kind of like grade group 1 prostate cancer, small renal mass? I mean, this is kind of akin to what we're doing in other urology spaces. Who's doing observation active surveillance? So quite a few. Yeah.
And that's great to see.
That's
right?
great.
Yeah.
Office fulguration, who would say this is excellent? So a lot of people have that set up in your practices. I think that's another wonderful way to keep people out of the operating room. And the last thing I want to ask is chemoablation. So I think we're aware of the novel compound from Urogen, not Jelmyto, but the term for the bladder component, but using the reverse thermogel with mitomycin. So from the faculty, if it gains approval in the near future, a patient with a history of low-grade non-muscle invasive bladder tumors in her situation, who would consider chemoablation?
I think I would stick to our active surveillance or office fulguration.
Yeah, that's a loaded question, right? Because again, the trials have been done and they're going up to the FDA, I think, next month, and they may get approved, may not get approved. But you have to think about the cost and what's involved, because it is treatment. You're treating the patient now with chemotherapy that's expensive, et cetera, in the hopes that you want to avoid a TURBT. So not for this patient, but in my mind, the patient that I would use that for in someone that's not a candidate for active surveillance, so the tumors are such that they're not within my trigger, well, they trigger a TURBT, but the patient's either too sick or they're on active anticoagulation, and I just can't take him to the OR. That's where I would use that. I would not use that in this patient.
I think so. The comment here, I certainly agree with that. A patient with a lot of other morbidities challenges getting them into the operating room. If the drug gets approval, I think that's a good indication. But I bring this up that we have alternative approaches. There's a lot. It's not just TURBT versus chemoablation. It's those two plus observation, office fulguration. Anyone else want to make a comment about chemoablation, about how you feel about it if the drug gets approval? Would others use it in different settings? Any last burning question as we wrap it up and put up the post-test question QRS code to remind you to please do those post-test questions? They're very important for the course and they're very important for the AUA. Everyone's good? Excellent audience, I have to say. We've done this course for many years, really engaging. Your questions were terrific and kind of made us go away from some of our cases, which is really the best way to do it. There it is. Again, thanks very much for attending.